Okay, good afternoon, everyone. Again, my name is Maureen Dobbins, and I'm the Scientific Director of Health Evidence, and I'm so pleased to have so many of you joining us today to talk about the Partnerships for Health System Improvement grant that we recently finished that included 3 public health departments here in Ontario that partnered with us around a knowledge translation strategy. So just before we begin, just some housekeeping. Just to make sure, so that everyone can actually see and participate in questions and answers. If you do have a question or a comment, please use the Q&A to post those questions, and please ensure that you're sending to all as opposed to the host privately. Certainly, if there's something that you want to just send to the host, you can do that, but general questions, it would be great if you would send to all, and then that way, when we get to that point of the webinar where I will go over any questions or comments, then everyone will be able to see those on their screen as well. And again, I know we've said this a few times, but if you are having any ongoing connection issues, we are suggesting that you use a wired internet connection versus wireless. We've just found over the years of doing webinars that results in a better experience for you participating. And if you're having any challenges, it's really best for you to call WebEx directly, and the line here, again, the number 1-866-229-3239. Okay, so today, the focus of this is a 1-hour webinar, and the topic is building capacity for evidence-informed public health decision-making. And this is the health evidence team, and this really was a team effort in terms of our conduct of this study, as well as all of the work that we do here at Health Evidence is a combination of our knowledge brokers, research coordinators, and research assistants, as well as a whole cadre of students, both at the undergrad and graduate level, who have been working with us as well throughout the years. So just very, very briefly, for those of you for whom health evidence might be new, healthevidence.org, really our whole goal is to help make it easier for public health decision makers to access the best available research evidence so that can inform their decision making. And Health Evidence is really an organization that is committed to making it easier to access evidence related to public health, as well at the same time conducting research in knowledge translation so that we can better understand what knowledge translation strategies are most useful and effective amongst public health decision makers in Canada. If you're not familiar with what our site looks like, this is what the homepage looks like, and newly reformatted and relaunched about a year ago, where we took some years of feedback from the thousands of folks who have used health evidence over the years and really worked very hard to improve the functionality and the usability of health evidence as the registry. So this is highlighting here the registry where we have accumulated in one place all reviews evaluating public health interventions that have been published since 1995, putting them all in one place and then doing the critical appraisal of those reviews, and that is accessible to you. And as well, we also have learned over the years that it's not just having access to the evidence, that it's also important to make it easier to use the evidence. And so over the years, we have developed a variety of tools that are also available that can help public health decision makers search for the evidence and also to interpret that evidence when they find it. So just very, very briefly, so that you know where we're coming from, we really use this model, the model for evidence-informed decision-making, to guide our work. And we certainly understand that public health decision-making is an extremely complex process that is made up of multiple, let's call it, ways of knowing. And you can see those here in these concentric ovals. And the FISI, as we call it, the Partnership for Health System Improvement Grant, was really focusing on the purple oval of research evidence, but then also bringing in and developing skill around these other factors as well, related to community health issues in the local context, community and political preferences in action, public health resources. So what is all of the evidence that we need at a community level or a regional level or a provincial level to make sense of all of that evidence, and then that public health expertise that everyone brings to that decision-making table to pull all of this evidence together and make the most appropriate, realistic, feasible decisions for that particular context, whether it be a local health department or a regional health authority, or even more broadly at that provincial or federal level. So this really guided our thinking about what we were doing in this knowledge translation intervention with the 3 health departments. And what we've learned over the years in terms of how does one actually go about doing or engaging in evidence-informed decision-making in public health, we've identified, well, we, the National Collaborating Center for Methods and Tools, really talks about using this 7-step approach. That starts with defining an issue, searching for the evidence, appraising that evidence, synthesizing all of the different evidence, adapting it to be locally feasible. If we make a decision to make a change in our practice, how do we go about implementing that? And then finally, how do we evaluate it? And so these, while you can start this process anywhere along this circle, so you don't have to start at the defined stage, what we've learned over time is that in order to actually work your way through these steps, public health decision makers need specific knowledge and skill in order to do each of these steps. And so that was really the focus of this knowledge translation study that we engaged in with 3 health departments, was to look at how we can build that knowledge and skill among staff in public health, those public health departments. Both today's webinar and the study itself were funded by the Canadian Institutes for Health Research. The larger study, the Partnership for Health System Improvement, was a 3-year study. And then more recently, we applied for what is called a dissemination grant. And with that money, we've been working on a series of papers to publish what our learnings were from this study, as well as hosting this webinar today. So as it's stated here, we call it FISI for short. The Partnership for Health System Improvement Grant is what we refer to in Canada as an integrated knowledge translation program. And what this means is that decision makers, in this case, these 3 public health departments, were very involved in the entire process of this research project. It meant that they were involved in the identification of the research questions that we would address, very involved in identifying the research design and the ways in which we conducted the research, the ways in which we collected data, thinking about how we would analyze that data. And then members of each of these health departments have been very involved with us as we've been looking at the evidence, looking at the data, and trying to make sense of what it means. And so we've engaged these public health departments multiple times, showing them the data and getting them to reflect on both their experience being a part of this study, as well as what they felt that data meant for them. So it's a very collaborative, applied type of research, and really in this case a real partnership between the research team and, in CIHR's terminology, our knowledge user partners. What you may or may not be familiar with is the FISI competition requires to have alongside the primary research investigator that you have a primary decision maker as well. And in this case, what we had was a combination of myself as the primary investigator, and then a senior decision maker from each of the 3 health departments were co-primary investigators as well on this grant. So we actually conducted a case study. Each of the 3 health departments represented a case. And as we have learned over our years of doing knowledge translation with public health organizations across the country, we truly understand that the knowledge translation interventions need to be tailored to the needs and structures of each organization. And so the case study design here allowed us to tailor this the KT knowledge translation and exchange intervention for each of the 3 health departments, and we tweaked that as we went. So as things changed, as we learned more, then we continually thought about and brainstormed what else we could be doing with that knowledge translation intervention. And then finally, the intervention was delivered by knowledge brokers. So in this case, knowledge brokers worked one-on-one with various folks in each of these health departments to help them develop the knowledge and skill, attitudes, and also at an organizational level to build that culture and context that valued the use of research evidence in decision making. We were specifically interested in answering what is the impact of a tailored knowledge translation and exchange strategy on knowledge, capacity, and behavior for evidence-informed decision-making. So that's really the quantitative side of the study. So did we actually have, did we see any change from pre to post along knowledge, capacity, and behavior? And then we also were very interested in understanding those contextual factors that either facilitated or impeded impact, with the understanding that what we learn about these contextual factors is going to be so helpful in helping us think about next steps and how might we be able to roll this out to more health departments or organizations across the country. So I'll just tell you a little bit about the cases. So case A was a very large health department, had a large population and a very diverse population. There was significant commitment from the medical officer of health and as well as the associate medical officer of health, as well as a long-term strategy to transform that health department into an evidence-informed organization. So a 10-year strategic plan that was a priority for that health department. And also multiple resources committed to making this change. Case B is also from a large urban center with a diverse population. There was medical officer of health commitment. We had an internal champion at the manager level who talked internally with others to encourage others to participate in the study, and as well a strategic priority focused on evidence-informed decision-making in this health department. And then our case 3 is a smaller mid-size public health department that serves a urban-rural mixed population. And again, there was medical officer of health commitment and also commitment expressed formally by the executive committee. In terms of who the KB interacted with, so the knowledge broker interacted at many levels during this study and during the intervention. The knowledge broker worked one-on-one with individual public health professionals. The knowledge broker also worked with teams and divisions, and then also focused at an organizational level. So thinking about what are the organizational structures and or processes that could be put in place to help support what was going on at that individual and team level. So it really was a comprehensive, I refer to it as an organization-wide knowledge translation strategy that we were proposing to do over just under a 2-year time period. So in terms of, I'm just going to talk for a few minutes here about what was actually done during that 22 months. So we can see here case A, the intervention happened between September 2010 and June 2012. The knowledge broker was physically on site 2 days of every week during the whole intervention. She mentored staff teams through what we call a rapid review process, so that whereby at a team level, important practice questions were identified, and then the knowledge broker worked with a team to work through that process of defining their questions, searching for the evidence, praising it, making sense of it. So there were 3 cohorts of these teams that went through this rapid review cycle during the intervention. The knowledge broker also provided general training, did one-on-one consulting. So one of the benefits of actually having her physically located on site 2 days a week with a desk and a phone and a computer was that she was very visible, and people could come by her desk and say, I have a question, could you help me with this? Or they could book a time to meet with her, and this was outside of these mentored teams. And then there were, throughout the 22 months, other, we call them EIDM related events, so opportunities to present at some various events that went on in the health department or attend some meetings that the knowledge broker also did. For case B, the intervention happened between April 2011 and February 2013. This is one of the cases where partway into the intervention, we thought about what was going on and made a few tweaks. So originally, the knowledge broker was on site 2 days of every month, and then virtual contact the other weeks of that month. This transitioned to having more regular on-site knowledge broker work in the latter part of the intervention, which allowed that greater visibility and a better opportunity for those that were working with the knowledge broker to book that time to meet with her when she was physically on site. So again, the knowledge broker mentored staff teams through a rapid review type of process, provided some broader training and workshops to bigger groups and teams, did other meetings and presentations as they were required, and then also fairly regular meetings with the senior management team to keep them up to date on what was happening, to continue discussing the study and the intervention, and to encourage others in the health department to become involved. And then finally, case C, the intervention was between April 2011 and December 2012. And this again was a site where we transitioned to more regular knowledge broker being on site. When we originally wrote the grant, what we proposed at that time was that the knowledge broker would be on site 2 days of every month and then virtual support. And what we learned as we really got into the work with each of the health departments was that it was really crucial that that knowledge broker be visible and available more often. So in this particular case, the knowledge broker ended up being on site 1 day every other week and had a designated spot where she worked, and that really seemed to help keep those engaged and created some really good interest in the health department. So again, here mentored staff teams through the rapid review process. This case had a research and knowledge exchange committee, and they created a policy and procedure that really set the groundwork for how this health department could embed a process of research evidence into their decision-making processes. So this was something the knowledge broker helped this committee work on as well during the intervention. And in addition, provided training as well as broad-scale workshops to all of the staff also happened, and this was something they particularly were interested in exploring in this case. In terms of the activities that were completed, in Case A, 18 rapid reviews were done during the course of the 22-month intervention, large-scale training sessions. The knowledge broker also contributed to a critical appraisal club, and then as we see here, other presentations to senior staff. Case B completed 5 rapid reviews. There was additional divisional training, for example, half-day workshops, ongoing presentations to the senior management, and then also abstracts submitted to some national and provincial conferences in which staff attended and presented that work. And then Case C as well completed 5 rapid reviews. They completed this policy and procedure document, which was then formally approved. Presentations were done, and then this training that was delivered over 1.5-day workshops to all of the staff in the health department. We collected quite an array of data over this study. Each case was really what we were only interested in looking at change for each case. So the purpose of this study wasn't at all to be comparing the health departments to each other, but to really look prior to and following the intervention, what happened with respect to knowledge, skills, and behaviors related to evidence-informed decision-making. And those represent the types of quantitative measures. And so we see here that we, at baseline, administered an online survey. This was a very short survey that asked questions around demographics. We also had a small component that was a social network analysis, so we wanted to know who did folks turn to for help with using research evidence in practice, who turned to them, who did they consider in the health department to be an expert in using research evidence in practice, and then who did they consider to be a personal friend, all things that we know are uniquely tied to information sharing networks. We also used a previously developed and tested tool that looked at evidence-informed decision-making behaviors. And so this asked a series of questions around how often do you read research studies, how often do you search for evidence, do you pass this on to colleagues. So a set of behaviors that have been identified as indicative of practicing in an evidence-informed way. We also created a new tool that was really looking at, though if you think back to that wheel that I presented earlier of the 7 steps, we identified specific skills that folks need to be able to perform in order to complete those various steps. And so we created a tool that, in a way, for lack of a better term, tested those skills. So that was those tools were administered at baseline as well as partway through the intervention, and then at the end as well. So following the 22 months, we surveyed everyone again. From a qualitative perspective, we also collected a fair amount of data. The CIHR self-assessment tool, that's the Canadian Health Services Research Foundation self-assessment tool. This is a validated tool that was originally developed for organizations to assess how well they were doing at integrating research evidence into their decision-making. And what this tool allows organizations to do is to assess themselves, to identify where they're doing well and what they want to continue to build on from there, and other areas that maybe they feel they aren't doing as well in that they would like to focus. It's a great tool in terms of allowing, and really this is you can create a strategic plan or a learning plan by doing this assessment. It's usually done by having everyone individually fill out the tool and then holding a focus group and facilitating discussion amongst all of those in attendance to discuss their ratings, and then as a group identify some goals and timeframes, and then you have this written plan that allows you to go back 6 months or 1 year later to assess how you're doing. So we administered that as well at baseline, and we usually use that tool even at that team level. So all the teams that engaged with us around doing a rapid review, we walked them through assessing their team with using this assessment tool. We also conducted interviews both partway through and again following the intervention. We interviewed folks that were very involved with the knowledge broker. We interviewed their managers and or directors, and we also interviewed folks that really weren't all that involved in the intervention. This is at a fairly senior level, to see what their perception was of although not very involved, were they hearing about the intervention? What was their perceptions of what was happening? And then finally, here on the far right of the screen, we used other types of documents to also help us make sense of all of the data that we were collecting through the quantitative and qualitative measures. So we asked the knowledge brokers to keep a daily reflective journal. This both chronicled all the activities that they did, as well as reflections from the knowledge broker on how that went, was there anything they would do differently, really, a way to really reflect on what was happening and what was being learned along the way and how that learning could be used to inform what we would do next. We also collected meeting minutes, other communications, email communications, and then collected documents. For example, many of the rapid reviews that were conducted resulted in a report being written, and we used those as well as other program planning documents to actually look at what impact this work was having on decisions. So as I have said a lot there, so just to put this all really into a nutshell, these methods were used to assess knowledge, skill, and behaviors related to EIDM, and then these latter data collection methods were really used to help us understand the contextual factors that either facilitated or may have impacted, were barriers to impact. So this slide just tells us a little bit about the response rates, and we can actually see here that there's some similarities in terms of the response rates. Of course, one of the challenges that is inherent in doing this research is that there's just so much going on in public health all of the time that it is really, really hard to have really high response rates, but we were happy with the response rates that we were able to achieve in this study. You can just see here slight variations in the response rates. And, I think as well what's important to keep in mind is that we learned different things as we went in terms of how to engage those in the study, and that is reflected as well, I think, in the follow-up. So I just see that there are a couple of questions, so maybe I will go take a look at those before I move on. So I see a question here that says, are you able to elaborate on the rapid review piece? Sure, I'm happy to go back and talk about that. So a rapid review generally happens from a particular team at a team level identifying a practice issue that they are dealing with. And in particular, during this study, we really encouraged at a health department level for them to identify priority issues. So issues that required a decision in the next, let's say, 3 to 6 months about a practice or about a program that they had in place. So the teams were involved in identifying these types of questions, and then the knowledge broker worked with this team. Sometimes it might have been 2 or 3 project specialists or a combination of a project specialist or research policy analyst and a manager working together through this through the rapid review process. And in other cases, it might have had more frontline public health professionals involved in doing these activities. So once the question was identified, then we worked through this process of further defining what that issue is, using what we refer to as PICO, P-I-C-O, and P-I-C-O refers to defining your population, identifying the interventions you want to know about, in those studies, what are the interventions being compared to? So that could be nothing, it could be whatever the standard practice is in place, or it could be a different intervention. And then the O stands for the different outcomes that you want to know about. So we help them further refine that practice issue into an answerable, focused question. We then work through the process of conducting effective and efficient searches for the evidence to answer that question, and really thinking about looking for more synthesized evidence. So let's say a practice guideline or a systematic review or meta-analysis. So going to those sources that have that type of evidence, and then if nothing is found, then ending up in the electronic databases where we can access single studies that answer that question. The next part of that process is then assessing the quality of that evidence. So how do we know which studies or which practice guideline has been done well enough to influence our thinking about a program? So working through that critical appraisal, then thinking about how to interpret what the results of that evidence mean, then thinking about, okay, so we found this evidence, 99 times out of 100, it will not have been conducted in your city or town or community. So how do we think about whether or not this evidence is applicable and feasible to apply in our community? So we have various tools to help folks do that, and then finally, moving into if a decision was made to change practice, how can a health department implement that change? So thinking about those types of strategies and then some evaluation. So that very quickly is, actually it's a bit more than the rapid review process really would stop at the synthesis stage and perhaps even that applicability and transferability stage. So I just see a couple of other questions. Is the online survey available to see? So we don't have that available for you to see today, but if you're interested in seeing the survey that we use, certainly contact myself or Robin Trainer, who I actually should have said is on the call and was instrumental as the research coordinator in administering this survey, and she'll be talking in a few moments about the qualitative results. So if you're interested in seeing the tool that we used, definitely let us know and I can make that available to you. The next question I see is, have you considered getting the KB from within the site rather than the particular, rather than us providing one? And so thank you. That is an excellent question. And, you know, there really are pros and cons to whether or not the knowledge broker is someone external to the organization or internal. Robin is going to talk a little bit more about what we found in this study was particularly crucial in terms of supporting an external person. So the last few studies that we've conducted from health evidence have really looked at this external knowledge broker. There are others. There's a paper published by Diane Russell where they did a train the trainer type of knowledge broker study, and they had a master knowledge broker that was external who then trained internal brokers within organizations. So there are different models. We have, based on the research we've done in the past, felt there's good evidence to support an external person, particularly at the beginning of a process like this, but certainly more research needs to be done to really get a sense of which one is optimal, or is it some combination of both. And then I just see another a question here is what kind of background training did the knowledge brokers have? So great question again. All of our knowledge brokers actually have a public health background, so they've worked in public health previously. They all had master's degrees, and then we provide training around the process of evidence-informed decision-making and that skill development, capacity development work. Again, there's so much more we need to learn really about knowledge brokers and what are the key components. My sense so far is that it really is helpful when the knowledge broker is knowledgeable of the public health setting. So having worked in public health, having been involved in decision-making in public health and a real awareness of how that works, I think is definitely important. However, my strongest hypothesis is that it has a lot to do with the personality characteristics. So it's a very special person who can really quite quickly develop a trusting, collaborative relationship with the public health professionals he or she is going to work with, trusting relationship, and one that's around, let's work on this together and to assist people in that way. Okay, so I'm just going to move forward with a few more of our results. So our demographics, really these three health departments were no different from all of the others, from the data we have of other health departments in Ontario. Primarily females who participated in our study. They actually have a fair amount of public health experience, on average about 12 years, but we can see here the confidence interval ranges from about 3 years to 20 plus years. And then, as we would expect, a very educated workforce with large section having a diploma. We have bachelor's degrees and master's degrees, as well as I think it was one person who actually has a doctorate. So let's just focus for a moment on what we found with what is the impact of this strategy. And I'm just going to go through these fairly quickly, but we did learn, this shows by health department statistically significant improvements in knowledge and skills in 2 of the health departments, and a trend towards an improvement in the second health department, but that didn't quite reach statistical significance. Oh, sorry, let me just go back there for a moment. In terms of what we further identified was that the knowledge and skills were most positively affected by those who worked intensively with the knowledge broker. So those groups that went through this rapid review process quite intensely with the knowledge broker were the ones whose skills we saw improve the most, as compared to when we did larger group 1 or 2 day workshops, or even multiple day workshops. It was more of that more intense training with the knowledge broker. In terms of what we label as the EIDM behaviors, this was the tool that identified its really 14 key behaviors around evidence-informed decision-making, and then you create that into a scale. And what we see here again is that only for those who were intensively involved with the knowledge broker did we see a statistically significant improvement in those behaviors. However, there are challenges with the measures that we use, and what we're struggling with really in the field of knowledge translation is one, sometimes you don't know what you don't know, and also before we really learn what it really means to say yes to some of these scale items, we might think we're engaging in these behaviors more than what we actually may be when we actually learn more about what those behaviors are. And so sometimes it actually looks like as people learn more, their behaviors actually look worse than what they did at the beginning. And what we also noticed here as well is we have a bit of a ceiling effect in that many folks were doing to some extent a number of these behaviors beforehand, and then there was some improvement for some of them after the fact. This just shows us a little bit more, again, what we saw from baseline to interim to follow-up. And again here, what we do see is the most improvement for those that were intensively involved. What also did emerge was, you know, the whole concept of practice makes perfect. So some folks were engaged in the intervention very early on, and let's say to partway through the intervention, and then their rapid review was done and they might not have become involved in another one. And so what we actually did see was a trend towards a losing of those behaviors over time, which is suggesting that there needs to be a mechanism in place to keep those new skills and new knowledge fresh in the mind and actively continuing to practice those ongoing. And I don't think we know yet just how long it takes for that to really become embedded in one's thinking so that, you know, you'll just automatically do it. But we think it definitely was longer than what we had built into this study. So around, just with respect to the evidence-informed decision-making behaviors, we did see a significant increase in behaviors in those who worked intensively with the knowledge broker versus when there was a large groups, those large group workshops, or if they weren't involved at all. And intuitively, that makes sense. However, the social network analysis data did indicate that those who didn't work intensively with the knowledge broker, but who connected with those who did work closely with the knowledge broker and who improved, those folks, that subset of folks themselves improved in their EIDM behaviors. So that's very, very interesting and very promising in terms of thinking about that train the trainer, internal knowledge broker type of model, that we could provide this intense training for someone in a health department. They themselves improve on their behaviors, and then others who aren't actively getting that intervention but who interact with them actually improve themselves. So something very interesting for us to be thinking about into the future, that we wouldn't have seen this pattern without having done this social network analysis. Centrality, again, from the social network analysis, we see some very important factors emerging. So someone who was considered at the beginning of the study to be knowledgeable, to be an important person around helping support evidence-informed decision-making. So you are identified by your peers at the beginning of the study as someone they turn to. Those folks tended to become even more central as the study went on and they received the intervention. What we also considered is that staff may have been learning these knowledge and skills, but we were trying to measure too quickly whether or not these new learnings had been put into practice. So we know again that it takes time for new knowledge to be put into practice. It takes time for decisions to work through that process of decisions and then being implemented into practice. So it could have been that we also missed some of that during the study. So I'm just going to turn the mic over now to Robin Traynor, who's actually joining us from Halifax today, and she's going to talk for a few moments about the contextual factors that facilitated or impacted the intervention. So I'm just turning your mic on now. There you go, Robin.
Great, thanks, Maureen. So as Maureen said, Maureen, I'm just going to, okay, there we go. So as Maureen said, the second and related question that we asked was, what contextual factors facilitate or impede this impact? And the impact being what Maureen just spoke about with respect to behaviors and skills. So to answer this question, we relied on qualitative analysis. Now, Maureen has already spoken about the various sources that we included, such as interviews, knowledge broker journal entries, and communications and meeting minutes that were incorporated into case study notes. So data from all three of these sources were managed and analyzed using in vivo. And two of our team members independently coded a few interview transcripts and journal entries based on an initial coding structure. We then compared our coding and further refined the structure as themes emerged using what's called a constant comparative process. And then one team member then analyzed all of the remaining data. So at this point, I want to take you through three aspects of our qualitative analysis that describe some common contextual factors across the health department. The first is related to the perceived value of EIDM, and the second and third relate to facilitators and barriers to EIDM, which I will discuss over the next few slides. Just to note, we have published currently one manuscript with qualitative data specific to the role of a knowledge broker, and I know that somebody was asking about things like knowledge broker qualities and characteristics. And we've also submitted another paper on practice tools and the usability and usefulness of these templates and processes for EIDM. So we will include the citations for those papers at the end of this webinar for anyone who's interested in reading more about those specific results. But getting back to today's discussion, I'll begin with the value of EIDM in public health. So the first theme to emerge was that EIDM is foundational. So public health practitioners recognize the importance and value of using research evidence to inform their practice. EIDM was described as being critical to one's work, a responsible way of doing one's work, and an important foundation upon which to practice. And this is common across all staff levels, from specialists to senior management, this idea that EIDM is foundational. Another point is that all levels of staff recognize that research evidence is really only one aspect of EIDM. What is needed, however, is to reinforce this understanding across the organization and then develop the skills to better incorporate evidence with the other inputs of decision-making. Several interviewees also identified having a pre-existing interest in EIDM as a result of either previous training or prior positions that they had held. So participation in this study either helped reinforce their interest or merely confirmed what they already saw value in. Other participants admitted that through the study they now had an appreciation for EIDM because they had either never thought about it before or because they had only been exposed to it more peripherally in the past. Related to this thought, then, is that some managers who we interviewed observed that the study intervention was most effective, or in general, EIDM was more likely to succeed or be picked up among staff who were already interested in EIDM. So the managers identified these staff as the self-starters. In other words, they were more likely to be engaged in the intervention, more likely to adopt EIDM into their work, and more likely to share their learnings with their peers because they had a personal interest in EIDM and understood the value of it without necessarily being told to understand the value of it by management. So from these two observations, we suggest that the study either helped reinforce a pre-existing appreciation for EIDM or developed a new understanding of its value for staff, and that this intrinsic valuing of the process is in turn critical for EIDM's success and proliferation in the organization long term. So now I'll talk more specifically about the facilitators, or the identified supports for EIDM. The first was having access to a neutral mentor, known as a knowledge broker, with expertise in knowledge translation and exchange. The knowledge brokers were identified as a critical support, both because of their knowledge and skills, but also the mentoring component of helping staff through a new and sometimes daunting process. The participants appreciated that the knowledge brokers were external to the organization because they felt less intimidated and more likely to admit their lack of understanding because the knowledge broker was both neutral and objective. They also thought that the knowledge broker was very approachable and always available to meet, which further enhanced the effectiveness of the broker. Secondly, having easy access to resources and tools was identified as a critical support. This meant knowing where to find the tools, as well as being able to access and use them easily. The knowledge broker was also helpful in this regard to direct staff to the tools and to mentor them on how to use them. Related to this point then is also the availability of a process or a template to follow. Some participants identified that knowing what was expected of them, so by following an established process or template, improved their understanding of the EIDM process in general and the expectations of their particular role as it related to using EIDM in the organization. So I touched on this last point on this slide on the previous slide, and that's the term champion. This term emerged in the qualitative analysis to describe several staff roles, including the medical officer of health and his overall vision for EIDM, the directors and the senior management team for setting an example and an expectation for EIDM within their directorates or divisions, the managers for providing capacity and encouragement for their staff, and then the staff themselves in the form of peer mentoring. So again, perhaps these self-starters. This peer mentoring was further supported by having a culture of inquiry in which staff were encouraged to share and learn from each other's experiences. And finally here, I have already identified the valuing of EIDM as an important contextual piece, but further to this point is the need to embed this value in the organization. So when EIDM was promoted as a strategic priority and encouraged through visible senior management support, staff felt well supported to do the work.
Robin, it's Maureen here. I'm actually going to just suggest I take over. It's actually quite difficult to hear you, and I just want to make sure that everyone is able to hear the content. So I'm going to take over with the remainder of the slides just to make sure everyone gets that content. But thank you. So of course, I'm sure you would all appreciate that this type of research and evidence-informed decision-making doesn't come without its challenges. And while all participants from all three health departments really have talked to many others about all the positive things that emerged from participating in this study, there were challenges. And so first and foremost, time and competing priorities. You would have noticed at the very beginning that I discussed there's quite a time difference in when the interventions started across the three health departments, and that really had everything to do with H1N1. And so H1N1 occurred, as we know, not once but twice, right in that same year that we were getting going with this study, and that significantly had challenges in terms of when we started the study. And things like that are happening all the time in public health. There are other crises and competing priorities that always are going to be there. And so it's actually, I think, one of the issues around doing a case study design that allowed us the flexibility to really try to explore this phenomenon of knowledge translation and evidence-informed decision-making in the real world as it exists for public health. But certainly those priorities represent a challenge to EIDM and the research. There can be limited engagement and the progress can be really slow. And so as a knowledge broker, it's really important to, really celebrate the small successes and to understand that change is slow and this isn't something that is going to happen overnight or in 2 weeks or a month or 6 months. It's a process of building and learning and going back and relearning while we think about how to embed this at an organizational level. As you can imagine, as folks become involved, they can be quite anxious or uncertain about what it is they're actually supposed to be doing, as organizations identify more clearly what are the roles and responsibilities for specific positions. So not everyone will, in a health department, will be doing all of these skills and behaviors. And what we learned, it was a process of learning along the way with the health departments in terms of who was best situated for doing certain parts of this process within the health department. But all along the way, that creates some amount of anxiety and uncertainty, which then also could impact one's willingness to engage. It was really, really important that communication be happening throughout the whole study. So very important that as the research team, we were communicating regularly with senior management and our key champions at all of the health departments, and then communication throughout the health department to all staff. In terms of potential challenges, you know, there's still quite a variation in how folks define what evidence-informed decision-making is. And really frank, open conversations about how people view that term, I think, is really, really important to be having at the beginning as well as continuing. You know, what the value folks place on different types of evidence. It's something that is really important to discuss and to really be open about in terms of some of these implicit hierarchies we might all bring to the table in terms of what constitutes evidence and what constitutes good evidence. So really good discussions around that is needed. We did hear from folks that, you know, evidence-informed decision-making isn't new, so why are we making a big deal about this? That it's not a novel concept. It's actually been around for a long time. But the issue here is in providing a structure in a systematic way to bring in the best available evidence that's available at the time, along with all of those other ways of knowing in our decision-making processes. So overall conclusions, we've determined that public health practitioners who worked most closely with the knowledge broker demonstrated improvement in both their evidence-informed decision-making behaviors as well as knowledge and skills. That those not intensively involved but who worked closely with this person who did work closely and who improved do show improvement over time as well. We did see an improved understanding of what EIDM is amongst individuals throughout the health departments. And we did feel that it is important that you have structures in place to sustain these behaviors. Otherwise, folks will regress. You know, we've heard statistical ideas regress towards the mean. Folks will regress back to what is something that might be more routine if those structures aren't in place to make it easier to continue to practice in that way. And understanding the context, we do feel, is really, really important to sustaining EIDM. One of the really interesting things, really as observers from the outside looking in, is that each of our 3 health departments really had to, and I use this word carefully, struggle with figuring out where to fit EIDM within their organization and within their structures. And each health department really found a different way to think about how to embed this as a routine way of doing their work. And they had to really grapple with how to find a natural fit for it. And then once they were able to do that, then folks were able to really, take a hold of it and really make it real for what that health department could and should do in order to support those behaviors. So I'm actually just going to back up. I know that we only have a few moments left, but I know there were several questions that were asked along the way. I'm just going to back up and take a look for those in the chat. So I'll pick up with the last question I answered was around the background training of the knowledge brokers. And the next question is, can you provide where to access the list of identified knowledge, skills, and behaviors for EIDM? So again, this was something that we developed for the grant. And if you would like to email So I'd be happy to make that available to you. It would also be inherent in that skills tool. So the skills tool that we created actually would identify what those specific skills were for each of the steps in the process. So the survey might meet your needs as well. The next question is, are these results changes in scores in the online survey or the EIDM skills tool or other? And so, so what I was showing you in those results slides was the skills tool measured the knowledge and skills, and then the online survey is where we ended up with the behavior measures. So the data would support both of those. The next question I see is, are these results changes in scores in the online survey? Sorry, I just answered that question. I see another question here that's around, did you measure or overall organizational change? It looks like you measured individual change. Organizational change would support keeping the skills. And that's an excellent question and comment to make there. What we did, it's really, really difficult to think about how to measure organizational change around knowledge, skills, and behaviors at that organizational level. So in this particular study, we focused on measuring knowledge, skill, and behavior at the individual level, and we looked at changes over time pre-post. From an organizational perspective, what we've pulled out more from the qualitative data is, were structures put in place at the organizational level that would help support these types of behaviors. So it isn't coming up with a measure of knowledge amongst all of those in the health department, but rather, is there, for example, some folks embed this now into orientation for new staff, or there's a policy and procedure that's been put in place about how they can do these activities. There's a policy in place or a checklist that the manager looks at to assess when someone has looked at a program and is coming forward with recommendations for practice, did they follow an evidence-based approach? So we looked at those types of, we used the qualitative data to help us identify what types of organizational outcomes could and should be emerging. And I think what we can think of now is how do we use that to maybe turn those and test those in a more quantitative way. All right, I'm just seeing what else, what other types of questions we have here. I know we've just gone a few minutes over time. Okay, so I don't see any other questions there. And we'll be putting these slides up, so you will see them. And here's just a list of some of the papers that have either been published or are in the process of being published from this study, and hopefully all will be available later this year. And then what we're just next steps in terms of FISI, we've actually presented these findings at a couple of conferences as well, and now we're waiting to hear on a subsequent grant, which we've labeled FISI 2, which has six other health departments in Ontario who have agreed to partner with us in taking what we learned from this initial study. We've thought more about what types of supports are needed at that organizational level and created what we call a knowledge brokering mentoring program. And we're just waiting now. We should hear in the next couple of weeks about the fate of that study. So I just see a couple of additional questions. Sorry, they're just moving on me quickly. Did you conduct analyses comparing people across educational levels? And that, we haven't done significant analyses by educational level. Your point is well taken there, that those who have higher levels of education may start better or do better. In the end, it's a relatively small sample that we have here in terms of those who worked really intensely with the knowledge broker. So we certainly can do some sub-analysis by education type. I'd be a little bit concerned in terms of really the generalizability of those analyses, but point well taken. I see another question here. Are there any tools to measure how people decide what is good evidence and what is not in terms of valuing the type of evidence? That's, again, another excellent question and point. We didn't specifically look at trying to quantify that in this study. Certainly in the interaction with the knowledge broker, asking people to think about this and discuss it, and really coming to a point of thinking about, we need all sorts of different evidence in public health to assist in our decision making, as opposed to dismissing certain types. But to my knowledge, I'm not aware of a tool that specifically answers that question. There's one final question here I'll take before we end for the day. If intensive work with the KB was needed to see maximal impact, is there a risk that this was more to do with the KB personality skills rather than just the KT strategy? So yes, that is a possibility. The knowledge broker, we had really 3 knowledge brokers involved in this study, and one of them was the knowledge broker for 2 of the health departments. And then in a third case, there was 2 that worked together with various folks in that health department. So we can't rule out that there's something about the particular personality skills or traits of that knowledge broker. We can, in this, we're funded with the second study, which involves a greater number of health departments and a slightly different kind of model in terms of the way that we can provide training for folks that would become internal knowledge brokers. I think we can look at that question a little bit more closely. Okay, well, thank you for staying with us as we've gone over time. It really was my pleasure to have all of you with us today to hear about the FISI study. A big thank you to all of the 3 health departments and all of the staff who have participated and given many, many hours to studying this with us. We couldn't have done this without them. And we're just finishing off with one question. So I know I've talked about the FISI 2 study where 6 health departments have agreed to partner with us. But if your organization is interested in working with us, we have a poll that's available for you to answer now. If you would like us to be in touch with you about working one-on-one with your organization, then please let us know, and we'd be happy to discuss that further. So that's all that we have for today. I thank you for your participation, and in the fall, Health Evidence will be starting up more regular webinars where we identify a well-done systematic review evaluating a public health intervention and presenting the results of those and implications for practice. So stay tuned for information from us on those webinars when they get going again in September. So thank you very much, everyone, and enjoy the rest of your day.